I'm very pleased to be able to interact with a very large number of you. I appreciate that, and I will do my very best to make this an interesting and meaningful presentation. So the title of the presentation, as you can see on your screen, is Aligning Competencies to Objectives and Assessment. I should say that this is particularly important as India is moving from towards the competency-based medical education model. I know a lot of activities going on, and I think it is therefore very timely that we discuss not only how to align everything, but also I'll spend some time on how to write these things. Because what I have found is this, that oftentimes I see objectives which are ambiguous, where the student has no clue what you exactly want. And I think if we are going to give a roadmap to the student, then the road signs and the pathway should be very, very, very clear. And then, of course, we have to align it all with our overall goal or competencies, as well as the downstream how we teach the topic, and then how we assess the topic. I say here, making competency-based medical education succeed, lessons learned. I started learning these lessons in 1995 when I started to convert from what I call knowledge-based curriculum to competency-based curriculum. It is at that time that I over a period of 3-4 years after that, I learned most of the things by making mistakes. All of us make mistakes when we start a new thing. Most of us are not trained in education, and I was not trained in education, so I made mistakes. And from those mistakes, I learned. So these are the things that I learned. The clearly articulated competencies and objectives. And I think I cannot emphasize this enough. This is exceedingly important, and therefore we'll spend a little bit of time on this as well. Then the alignment of competencies and objectives with the instructional design. I think, again, you can have great competencies, and you could have an inappropriate teaching methodology, and that will then, of course, not succeed. And then alignment of assessment with the instructional design, competencies, and objectives. And then there are 3 other points which I will not discuss at all today: structured feedback between teachers and learners, ongoing faculty development, alignment of all the stakeholders. And may I just point out in this last bullet point, stakeholders includes students. We tend to exclude students from curricular decisions that we make. And I think we miss out an opportunity to understand, how our students learn and what their expectations are, and to tell them that we are making these changes for the following reasons to improve your medical education. And I think students should be a participant in that particular discussion. I know it is not common in India. I hope it will be going forward. Because they are our stakeholders. Ultimately, it is they who have to benefit and go and practice medicine. We can give the best course, but if it doesn't get across to a student, we have failed. Okay, so with that, the first point in this is clearly articulated competencies and objectives. Let me just say that the next slide shows my definition of competency, and you don't have to agree with exactly the way it is. I have seen competencies written in other forms, more precise forms. This definition comes from at the bottom you see AAMC HHMI report 2009. In 2009, American Association of Medical Colleges convened a task force of 10 leading medical educators in the country. I was one of them. I had the privilege of being one of them. And we worked very hard to define competencies and then to design objectives underneath the competencies. So I'll just read it. You can read it also. Competency is knowledge, skill, and attitude that enable an individual to learn and perform in medical practice and to meet or exceed the standards of the profession. Competency is not what you know, knowledge, but what you can do. I think all of us will agree with this definition. There may be other forms of this definition. Okay, that's unimportant. So here's an example. So what we did was we wrote overarching competencies. Okay, and again, one doesn't have to write it in the overarching competencies. One can write down narrower competencies than what I have shown here. And so this is the overall competency for teaching immunology and learning immunology. And it says each word is very carefully selected. So let me go over it. Apply the principles of the cellular and molecular basis of immune and non-immune host defense mechanism in health and disease. Now we could have stopped the example of the competency right there, but we decided that there should be a reason why this competency is being put in place. The student should understand what the reason is. So therefore, it says to determine the etiology of disease, identify preventive measures, and predict responses to therapy. Now this gives a rationale to the student as to why they should know the principles of the cellular and molecular basis of immune and non-immune host defense mechanism in health and disease. So, in structuring competencies and objectives, we took care always to include within the sentence a rationale for why the student should feel that this is important for them to know. And this is again a way of involving the stakeholder. So I think this is again something that all of you, I'm sure, have gone over multiple times. I just want to add one more thing. Educational objectives are specific targets within the general goal or competencies. Now, the term goal and competencies are often used interchangeably. In my view, goals are broader, competencies are a bit narrower in a sort of hierarchical system, and I'll give you an example of that. Now, objectives interpret the goals and focus and prioritize curricular components. They are narrow and time-bound to achieve a certain specific task which can be measured. Goals may be intangible, while objectives ought to be tangible. So goals can be very, very broad, as I just stated in the previous one, but objectives should be very tangible, very specific, very focused, and unambiguous completely. And furthermore, objectives are learner-oriented and are stated in terms of the learner's behavior at the end of the instruction or a course. Again, this is not novel. I'm sure many of you who have taken courses in your NEUs have gone through this particular thing. Okay, this is where I think I think this is one of the next few slides I believe are exceedingly important from my point of view. So, as I say in the title here, competencies and objectives, hierarchical relationships. They have a hierarchical relationship. One is above, the next is below, and the next is below. I go to 3 levels, okay, and I'll show you those 3 levels and how they relate and align with each other. So we wrote the level 1, okay, we can call it the goal or we can call it competency. Frankly, it doesn't matter. It's a very, very broad competency. It is a competency that applies to all of pathology. So we said apply the mechanisms of general and disease-specific pathologic processes, which is general pathology and systemic pathology, in health and in disease, and note the highlighted portion, to the prevention, diagnosis, management, and prognosis of critical human disorders. Again, giving a purpose to the student for why this competency is essential. Okay? And then next in the hierarchical system is the objective. I will call it level 2. You can call it whatever you want. I always think of in 3 levels. Level 1, level 2. Now level 2 is the objective. Now the written objective here is, you can read on the screen, describe the cellular responses to injury. I have seen many objectives written just like this. Frankly, this is a very bad objective, because this is as good as telling the student, read pages 25 to 27 from the textbook. Okay. And And I've seen examples where they add the word to be able to describe. By adding to be able to describe, it doesn't become a good objective. A good objective should be very focused, very sharp, and very clear. So, so if you want to write an objective on cell injury, this is a good example. Apply knowledge of cellular responses to injury and the underlying biochemical and molecular alterations. Why? To understand, to assess therapeutic intervention. Okay, so this is now guiding the student in a very specific pathway. Okay, with this very specific goal. Okay, then comes the level 3. Again, level 3. Sorry, go back. Okay. So okay. Again, an example. Describe free radicals and how do they affect cells. And by writing be able to describe, this doesn't become a good objective. What makes the good objective? When you specify very clearly. Instead of saying describe free radicals and how they affect cells, I have said explain how free radicals are formed and removed from cells. Okay. And conditions under which free radicals can benefit the body, such as injury to microbes and phagocytes, or cause tissue injury, as in reperfusion injury. So this gives students. It doesn't say read page 25-27, but it says when you read page 25-27, this is what we want you to focus on. How are they formed? Why are they useful? Why are they harmful? It connects the objective to the task, or the knowledge to be gained, or the competence to be acquired. Similarly, describe the formation and effects of misfolded protein. Vague. Specific. Relate the occurrence of misfolded proteins to the causation of human disease. For example, Alzheimer's disease. And then highlight it. What therapeutic interventions might prevent the harmful effects of misfolded proteins? You can't understand therapeutic interventions if you don't understand the mechanism. And why should you know the mechanism? So that you can learn and think about how to intervene therapeutically. And this gives the student a precise roadmap and also tells the student why it is important. Once the students understand why it is important, they are much more motivated to then go and think about it and learn about it and discuss about it. Another example, I'm going now from again level 1 to level 2, and then we'll go to level 3. The level 1 is the general competency for all of pathology. Level 2 is the objective, applying to cancer, and it is apply the knowledge of the molecular basis of neoplasia to an understanding of the biological behavior, morphologic appearance, classification, diagnosis, prognosis, and targeted therapy of neoplasm. Okay. This is more specific than the level 1, but still not very specific because it covers biological behavior, morphologic appearance, classification, etc. But it gives a pathway. And it becomes specific when you go to level 3. It doesn't matter whether you call level 2 objective or level 3 objective, as long as it is clear in our minds, the student's mind, that there's a higher level, there's a middle level, and there's a lower level. In the lower level, as we go down the levels, we become more and more specific. Okay, so level 3 example, cancer genes. Okay, now we are coming out to the level of the last level. So A bad objective would be describe the actions of oncogenes and tumor suppressor genes. I've seen this written many times. I've read it many times. Okay, uh, you know, this is covered in about 8 or 9 pages of most textbooks. Okay, and it's just that if you just say what the orange line says, you're telling the student go read those 9 pages. You're not telling the student what competency you should acquire by reading those 9 pages, or what is the objective in reading those, and that is specified in more clear terms as compare and contrast the action of genes that promote cell growth, which are called oncogenes, in cancers with those that inhibit cell death, which are called tumor suppressor genes, and explain how this information influences the choice of therapeutic agent. So the treatment of nodular B-cell lymphoma and large B-cell lymphoma is quite different because of an understanding of which cancer genes are mutated in these conditions. So obviously I will not going to talk about therapy, but I gave that as an example. Nodular B-cell lymphomas are caused by defects in apoptosis. The cells don't die. And large B-cell lymphomas are caused by defects in proliferation. And they're treated very differently. Okay, so I think all of you know the type of learning outcome. Cognitive domains, intellectual skills and abilities; affective domain, feeling, values and attitude; psychomotor domain, physical skills. Now, objectives can be written for any one of these domains and should be written for all of these domains. The examples I gave you previously were all in the cognitive domain. Now, I'd like to give you examples of objectives in the affective domain and psychomotor domain. Okay, so in clinical medicine, what one needs to sort of not only have cognitive skills, but also psychomotor skills, and also have in the affective domain. So here's an example of level 1. Perform a comprehensive assessment of cardiovascular system, including physical examination, EKG, and imaging modalities. Objective: apply the knowledge of cardiac blood flow and hemodynamics to the nature and location of murmurs elicited by auscultation. So now here the student is being told, acquire the knowledge and apply it, acquire the knowledge about cardiac blood flow, hemodynamics, so that you can understand and you can elicit the nature and location of the murmurs elicited by auscultation. So now auscultation is a psychomotor skill. It's not a cognitive skill. And then we come to level 3, which is again in this, you can see there's a level 1, there's a level 2 and level 3, and each one of those becomes more and more narrow and much more focused. And the example here, level 3, is perform an accurate measurement of blood pressure using a sphygmomanometer, both in standing and lying position, with an accuracy of 100%. So this is largely a psychomotor skill, how to take blood pressure. So here are some guidelines of action verbs that one can use for different levels of objectives, okay? Different types of objectives. So the action verb recall is basically to retrieve previously learned information. That's all. It's not asking for any other thing. So oftentimes the verbs used are list, define, recognize, state. The action verb comprehension now goes further and is designed to discover the meaning of the information. For example, classify, summarize, explain. Action verb application: use previously learned information in a new situation. Apply, compute, illustrate, utilize. You'll see examples of this. Action verb analysis implies examine information and break it into its component parts to identify, make inferences, determine relationship, or draw conclusions. The verbs often used are relate, compare, contrast, and distinguish. Action verb synthesis. Apply prior knowledge and skills to produce something new. Propose, hypothesize, construct, organize. Action verb evaluation. Making judgment now on the basis of a given criteria. For example, interpret, estimate, critique, assess. So you see, depending on what your goal is, you can use a whole variety of action verbs, and with each of these action verbs sort of goes to a different level, if I may say so. The last one, evaluation, is judgment. Interpret, estimate, critique, assess. The first one is strict recall. And in general, I personally avoid strict recall objectives unless they are attached also to why you should recall, what you should be able to do with what you recall. So here is an example, series of examples I created to illustrate the point I just mentioned. Okay. So objectives can be tools for recall, or they can be tools for competency. Okay. And I will give you examples on the same disease, rheumatoid arthritis, how one can write objectives which change from the strict recall to competency. Okay. So list the cytokines that are produced in the joint affected in rheumatoid arthritis. So just list, TNF, IL-1, TGF-beta, etc., etc., etc. This strict recall. Okay. And the next one says, deduce the morphological changes in the rheumatoid joint resulting from the cytokines produced in the joint. Now remember, please note, the second one actually requires knowledge of the list. But we are no longer asking for the list. We are asking you should know the list, and from that list you should be able to determine or predict or understand what are the morphological changes in the rheumatoid joint. Okay? Synovial proliferation, callus formation, etc., etc. The next one says, predict the class of drugs and agents that are likely to have therapeutic value on the basis of the action of cytokines found in the rheumatoid joint. Once again, to address this objective, one has to know the list of cytokines. But now the student is being asked to use that list, okay, to predict what are the antagonists to various cytokines which could be useful in treatment of rheumatoid arthritis. The class of drugs and agents that are likely to have therapeutic value on the basis of the action of cytokines found in rheumatoid arthritis. Now, I think everyone knows that rheumatoid arthritis is these days treated with drugs that inhibit the action of TNF-alpha. They have turned out to be exceedingly one of the success stories of modern molecular medicine. The last one is asking for a higher level of judgment. Okay. And it says, prioritize the likely efficacy of different immunosuppressive modalities. Prioritize efficacy, different immunosuppressive modalities in the treatment of a patient with rheumatoid arthritis on the basis of the relative amount and potency of the cytokines found in rheumatoid arthritis. So this objective is at a much higher level. This is for a postgraduate level objective. It's not for undergraduate, because in this one is asking the person to have a certain level of judgment, and judgment comes from experience and a broader scope of knowledge. But I hope you see the top one is strict recall, and the last one is high level of competency. And within the same disorder, same disease, one can construct objectives that are at different levels. Okay. And I would say that for an undergraduate, second one, reduce the morphologic changes is a very reasonable objective, as well as predict the class of drugs and agents that are likely to have therapeutic value on the basis of action of cytokines on the drug. Okay, we continue with some examples of competencies in the clinical arena. And here I go from my area of expertise to an area which I'm not particularly expert in. Okay? But I still, you can see how these are structured. So again, level one is be able to diagnose and manage pregnancy-induced hypertension by clinical features and laboratory investigations, and develop a plan of management in the context of the signs and symptoms and capsules disease. Very broad, very, very broad. Be able to diagnose, be able to manage based on clinical features, lab investigations, and then develop a plan of management in the context of the signs and symptoms and capsules of the disease. You have to know a lot to be able to have this level of competency. Okay? And frankly, this level of competency, I would think, would be more appropriate for postgraduate students than undergraduate students. Then we come to objectives. Okay, level two, in the cognitive domain, using different action verbs that I give examples of. Recall, remember, comprehend, understand, apply. And as you can see, as we go down from recall to comprehend to apply, we are going towards a somewhat more sophisticated statement. Similarly, action word, analyze. On the basis of clinical and laboratory findings, categorize a patient into mild or severe preeclampsia according to ACOG 2015 classification. Evaluate. Compare the risks versus benefits of continuing conservative management and delaying delivery in severe preeclampsia on the basis of the understanding of underlying pathophysiology. Evaluate. Create. On the basis of understanding of the pathophysiology of hypertensive disorder pregnancy, predict the biomarkers which may be utilized for early detection of preeclampsia. Okay. Yeah, this is a complex, objective, and it requires a student to create a list on the basis of pathophysiology and understand the pathogenesis of the disease. Then all the examples previously have been mostly in the cognitive domain. There are some examples in the affective and psychomotor domain, and it's thought. So in the affective domain, during an eclampsia drill, the student demonstrates the ability to recognize and respond to the emergency, call for help, and organize the teamwork to the satisfaction of the drill. Psychomotor, in a simulated eclampsia drill, demonstrates the ability to manage a convulsive movement by changing position, head tilt, introduction of mouth gag, and starting a magnesium sulfate infusion as per checklist provided. And synthesis of all domains, collect a pap smear in the correct stepwise manner as per the checklist provided after counseling and explaining to her, the patient, the need for cervical cancer screening on the basis of the knowledge of the natural history of cervical cancer. This is of all the domains. It has a cognitive component, there's a psychomotor component, and it also has an affective component. Because you have to sort of explain, to the patient, not just sort of say this is what we are going to do. So, I hope that in the preceding 15, 16 slides, uh, I have explained to you, hopefully, in a manner that was comprehensible. So that is my competency. how, how competently did I uh, convey the definitions and the writing of competencies, objectives, and examples, which are basically three different levels of the outcome. Ultimately, whether we call them objectives or competencies or levels or so on and so forth, there's an outcome which is a desirable part of it, and that's the goal towards which we have to do it. And what I've shown you is one method of doing it, but I think these principles will apply no matter what subject and what topic that you are dealing with, your personal expertise. Okay. So I think in this list of things which make competency-based medical education succeed, some of the lessons I've learned, one of the lessons I've learned is this, that the competencies must be alignment of competencies and objectives with instructional design. So you can write the most beautiful objectives and most wonderful competencies, but if the instructional design is not aligned to them, I think the outcome will be less than optimal. This is a vast subject by itself, and I'll just give you an example of how I did it 7 years ago. So before we go there, okay, the traditional instructional design has placed excessive attention to impart ever-increasing knowledge through lectures, cramming of new information into progressively shorter schedules at a time when information is readily accessible. I mean, your iPhone, your cell phone has all the information that you could possibly need. Okay. It's not organized, but the information is available. Okay. And I think the traditional way of teaching has been heavily lecture-based, and I think we teach too many facts in a passive mode. I think all of you know passive and active modes. And there's insufficient attention to skills of data gathering, synthesis, integration, and application, which is a competency we are seeking. We do not teach how to acquire facts and apply and integrate them in an active logic. And curriculum is driven by measurement of knowledge in the form of facts rather than measurement of competencies. With questions like that, which of the following is true of this? Okay. Mostly questions which are sort of based on listing. List the most important cytokines found within the gut joint. Or list the cytokines found in the gut joint, and then you give 4 wrong ones and 1 right one. So this is sort of, I'm just going to tell you in a very, very condensed form how in 1995, when I was in charge of teaching pathology in my medical school, how I, along with my colleagues, changed from the traditional curriculum to a revised competency-based curriculum. So we are given 255 contact hours, by the curriculum committee. And until 1995, we were using 160 of those, almost 2/3 of those in lectures. This is not uncommon. We used to have 3 or 4 lectures per day. And the course ran over a 9-month, 8-month period, or 1-year period. And then we have laboratory exercises in which students would take out the microscope, look at the class slides, write a description of it. We would also show them growth tissues at the same time relating to the subject matter study. We revised the pathology curriculum to make it competency-based from 1996 onwards. The total contact hours remain the same. Okay. So I think if the Board of Governors or the NCI, the regulatory bodies say, you should have 190 hours of pathology, that's fine. From what I understand, they don't force you to use 90% of the time in lectures. It's then up to the institution, the course directors, the faculty to decide how to distribute that particular time. If I'm not wrong, I've been told by many medical lectures in India, that um, there is no compulsion to use most of the time in the form of lectures or pencil learning, and particularly now that we are going towards competency-based education. So what did we do? We turned thinking completely upside down. We developed 100 cases, and we used most of the time in case-based discussions with very active participant interactive process, during which the students could be challenged, the students could be asked to synthesize, students could be asked to use judgment by asking appropriate questions and eliciting the responses that lead to the competency in that area. The lectures are reduced to about 50, 60 hours, and even these lectures which were there, they're no longer everything that you can know about rheumatic heart disease, but a very broad, overarching, conceptual lectures saying, these are the ways one should approach the study of ischemic heart disease or heart disease. These are the valves, these are the myocardium, these are this, and in general, these are the valves cause murmurs, these are the myocardium cause ischemia and injury, and so on and so forth. Okay? Rather than the mitral valves are thickened and can't move in after rheumatic fever. And that's what's left to the students to acquire in the form of their reading, guided by very well constructed objectives. So I think, again, I'll go through this quickly because I think all of you have heard this thing before, but I just thought it's important to re-emphasize it. In active learning, the role of the instructor is to clearly articulate the competency and objective. We just talked about articulating competency and objectives a little bit. The teacher plays an active role in problem-solving phase for this case discussion or problem-based learning, depending on what method you want to use. The teacher brings to bear years of experience that cannot be acquired from textbooks. Lectures, not mere recitation of facts available in study textbooks. Students, you ask the students, they will tell you. At least our students told us. 80% of the lectures, content lecture, you could have told us to read, that many pages. We haven't added anything new at all. What we want is, we want to learn how to use that information. So students acquire most of the facts, information by themselves from various resources, and we give them various resources. And then the role of teacher changes from purveyor of facts to facilitator of application. This was the most difficult thing, the last one, because many teachers and faculty who have been teaching in the traditional mode completely believe that there is no method other than their lectures which is better. I am the expert. I know how to teach. Okay? Don't tell me how to teach. And we faced that resistance from people. And these are well-meaning people. These were not people who were unreasonable or stubborn. They just truly believed that was the best way to do it. And we said to them, okay, you just tell us. You write the objectives. You tell us what the student should get from your lecture. Okay? And, they went through that side of writing competency and objectives. And we said then, all right, create a few cases. Okay? You're the content expert. Create a few cases. During the discussion of which the students will learn those, be able to acquire those competencies and learn what is desirable as pointed out in the objective. And with that kind of discussion, we were able to convince everybody, all faculty members, that this is the way to do it, and it was highly successful. I think I skipped this one. So the next point is this, that in the alignment discussion is this alignment of assessment with competencies, objectives, such as that. Now, you can do everything perfectly. You could have great competencies, you could have great objectives, okay? You could have, very active learning exercises, PBL or case-based discussion and so on and so forth. So you can kill it all by inappropriate way of addressing. The students, if you tell the students this is what we are trying to accomplish, and then give them tests which are strictly false, the students say the teachers are liars. We can't trust them. And once the link of trust between the teacher and the student is broken, then the whole system breaks down. So I think that's very, very important, is that your assessment methodology should be in alignment with what you told the students the competencies is required. So let's go to that. So here is an example of a multiple choice question. Okay, we use only multiple choice questions, and I am not saying that other ways are inappropriate. There are other ways of doing it also. But in the US, this is what we use, and so this is what I have most experience with. Okay, and that booklet that you have, let me just see, for pre-reading material, okay, is sort of the Bible for those of us who are using this method of assessment. Okay, so let's just look at this question. Okay? A 60-year-old male presents with easy fatigability. Physical examination is unremarkable. Laboratory investigation revealed hemoglobin of 9.7, that's 9.7, hematocrit of 39.9, MC of 69.7, and RBC count of 4 million. Stool is guaiac positive. Radiologic investigation revealed the presence of an irregular mass in the ascending colon. A colonoscopy and biopsy was performed. Okay. Which of the following molecular abnormalities in this lesion is most likely to render the cells resistant to chemotherapy-induced cell death? Okay. So we are testing scientific competency in the clinical context. Okay. First of all, the student has to be able to read and come to the conclusion 60-year-old male with iron deficiency. And then notice that the stool guaiac is positive. Start synthesizing. And next, radiological CT scan or something showed a mass in the colon. The colonoscopy was done and a biopsy was performed. We are not telling the student what the biopsy shows. We are not asking the student what the biopsy shows. We could have. Okay. But in this case, we are trying to test their scientific competency in a clinical context. And we are trying to test what they know about cancer genes. Okay. But we are asking the question in a very applied clinical form. So the student understands why we are asking this question. We are saying which of the following abnormalities is most likely to render the cell resistant to chemotherapy-induced cell death. Chemotherapy is practice of medicine. One has to know how chemotherapy works. The answer is, of course, mutational inactivation of P53. Now, a question, a different form of the question, which would be less satisfactory, would have been, which of the following genes controls apoptosis? Okay, so now basically it's a recall. You have to recall the function of the RB gene, the RAS gene, P3 gene, APC gene, and F1 gene. On the other hand, I think that if you know that chemotherapy kills by apoptosis, you go directly to the gene that controls the apoptosis of P3. This is a very clinical and morphological question. It tests the competency in integrating clinical observations, laboratory data, and morphology. I won't read the entire history. And by the way, I'll make the slides available to anyone who wants later on. But there are some slides coming very, very soon, which are copyrighted by the National Board of Medical Examiners. I'd appreciate that you would not take screenshots of those. So this is a patient who comes initially with a history of very well defined history of diabetes mellitus, hemoglobin HbA1c 10%. Students have to be able to interpret all those things. Okay. And the biopsy is taken and biopsy is shown. Okay. Many years later, the student comes back and the students have to now see that the patient has come with renal failure. Creatinine is up, BUN is up, and he's conscious, but he appears disoriented. And the question is, which further clinical exam is likely to reveal which of the following clinical findings? So you see, the previous question was very hard science. This question is very clinical. And it asks the student, given this sort of context, given this history, given this biopsy, when you do additional clinical examination, what will you find? Okay, so now the student has to know the clinical features of diabetes mellitus and its complications and apply them to this in this form. This question tests competency to synthesize clinical, radiological, histological findings with discipline knowledge. Very simple question. 43-year-old male had cough and fever for previous 2 months. Chest radiograph shows nodule densities with calcification, mostly in upper lobes. The microscopic appearance of lung biopsy is shown. Which of the following chemical mediators is most important in the pathogenesis of this disease? Okay. Interferon gamma. Okay. Why do we ask this question? Well, in clinical practice, clinical pathology, interferon gamma levels are measured. In a patient who is suspected to have a granulomatous disease, particularly tuberculosis, it's used as one of the important sort of lab tests that support the diagnosis. Is based on understanding the mechanism. So, the clinical features given here, they are very simple because this question was used for students in the very beginning part of the general pathology course, in the pathology course. They had been in pathology only for a couple of months. Okay, so we didn't want to ask them a clinical question which is too complex. And I won't talk about structured feedback between teachers and learners, ongoing faculty development, and aligning of stakeholders. I mean, these are, as you can see in my experience, there are 6 lessons that I learned to make competencies and students succeed. And the points I'm not going to discuss are not unimportant. They are very, very important, but I'm sure you'll have other sessions on those. Okay, now I'm going to focus just on my talk. I have about, I think, 15 minutes, but if you permit me, I might go somewhat over. Sanjay, can I go about 10-15 minutes over? Sanjay, can you hear me?
Yes, sir. You can take another 20-25 minutes.
Okay. All right. Okay. I will try to go through this in a reasonable.
Yes. Some people have raised their hands. There are a few question answers also, but we will take them.
Okay. Oh. Yeah, let's keep the question answer. So
Yes.
I just sort of requested you on this slide. Many of these questions are copyrighted by the Psychomotor examiners, and they have given it to me very for teaching purposes. And all of them, every single one of them, I emphasize, every single one of them is discussed in this period. In fact, many of the very same questions are used in there to make the point. Okay. So I won't spend time on this. 2 false questions that were used by USMLE. There are the golden booklet discusses in far much more detail as to what are we are going to stick to multiple class questions with one depth option. So you look at the structure. There is very detailed history, clinical examination, voluntary tests are provided. The student is being asked to synthesize all that information because of all the most likely. This is not for second-year medical students. This is for students who have already had a fair amount of clinical exposure. And we won't discuss these, but I want to use this one as for to remind you of the first important principle in designing a good MCQ, and that is called the hand test. The hand test means you can cover the choices with the hand, and the student should be able, by reading scenario-based, as we call scenario-based, the diagnosis. The student should not have to go through A, B, C, D, C and decide which one is correct. The student should know that under the hand, in position number B, under the hand, in this list, there is the correct diagnosis, and it's split by a syndrome. And the student then no longer says, is A correct, B correct, is C correct. Student goes directly to the one. If he or she knows the medicine, go direct to the one, it's up. And this student can answer the question in roughly about 45 seconds or 1 minute. And a student who has to go through A, B, C, D, E, it gets so long that they will not be able to complete that exam. Okay, so come back to that. In this case, correct diagnosis was William Barrett syndrome, and a student who has acquired the competency, will look at the list and say, William Barrett syndrome. Okay, it's B. My answer is B. Now, if you notice in the previous example, the choices given are all homogeneous. They're all diseases, and they're in fact all diseases of motor muscle. Okay, so there should be homogeneity of the choices, and I'll give you examples of that is not true. Okay, options must be homogeneous. In this case, all diagnoses. You must be able to rank order the options in the same diagnosis. The most correct answer, least correct answer, and those sort of may have some features in the scenario. So rank order on the same dimension. Okay, here is the flaw one best answer. Which of the following is correct? What are the flaws in this? Flaws are using the term frequently, seldom, maybe associated to it, clearly, responsive. Why is it flawed? Because everybody's conception of what is frequent, what is seldom, what is different. Okay? The student has to guess what the instructor said. And the next board examiner took a very large number of students and gave them these terms and asked them to say, okay, when somebody says most of the time, what do you think? Well, you think between 75% and 90%, the median is 80%. When the word usually is used, the word frequently is used, and almost you see the problem is this, that usually and frequently overlap in the minds of the student. Okay? Most of the time, and usually overlap. The student has no way of knowing what is your intention. What do you mean by it? So those terms should be avoided. And next, it is the hand test. Which of the following is true about philosophy? You have no idea what you're going to be looking for. So this is a bad question for two reasons. Vague terms, failing hand test. And in this is the further analysis, which is available in the book. So if you look at these 5 choices, it's not homogeneous. A is gender. B is association. C is also association. D is inheritance. And E is speaking. Each one of those is in different language. And the student has a really hard time ranking these because they are all when compared to the physical disease. That's the way to do it. Another flawed item. In patients with advanced dementia, the memory defect, you don't know what's coming next. So you fail the hand test. But it also fails health test. A vague term like, can be treated adequately. So what is adequate treatment? 50% response, 90% response, 20% response. in a leadership system, 30% response might be adequate. Could be sequel or partial is never seen. Students know immediately when the word never comes to the first combination of cells. There's nothing there to it. So they remove C and D from the list is in a minute. And now they're wondering what should it be possibly, what should it could be, what should it can be. Again, the options are non-homogeneous. Okay, one is treatment, one is pathogenesis, one is morphology, and so on. And then there's another class of flawed item which is called the convergent issue. It is called the convergence problem. Local anesthetics are most effective in the, again, you fill the hand test. But here are the choices given. Okay, and now these are choices. First of all, it's tedious to read them. Okay? It shouldn't be. You should not be testing students' sort of ability to read fast. Okay, that's not the goal. Okay, but students a student who does not know what the correct answer is going to look at this thing, and if he or she knows how to take tests, you get to the right answer without knowing anything. Okay. The first thing is this, that there is anionic, cationic, uncharged, uncharged. Okay, the student says anionic appears only once, and if the correct answer was anionic, the test writer would have given anionic choice on 2 or 3 different options. So they say, okay, anionic analyzed it. Okay. And cationic form and uncharged form occur in 4, so that's gone. So these are both used twice, so it could be B, C, D, or E. Okay, and then they say, okay, acting from inside, acting from inside, acting from the inside. Okay, act from inside appears more frequently than acting from outside. So one of those is correct. So when you do that, you already said that it is going to be not going to be anionic form. It can be this. But now you've also said it's acting from inside. So the correct answer is cationic form acting from inside. So this is called a convergence problem. The student can sort of take the options and converge to the right answer without knowing anything about it. Okay, then there are irrelevant difficulties that poses a challenge to the examinee that is unrelated to the questions. Here's an example of flawed item. I won't even read it. The reason I won't read it is it's flawed because it is really testing reading comprehension. It's a very long, tedious set of choices, proper notice, tribunal empowered to make a decision, a chance to confront witnesses against him or her, and a chance to present evidence of defense. This is structured in a way that it will take 3 or 4 or 5 minutes just to read it and understand what is being asked. Okay. So this is irrelevant difficulty. Another flawed item. Following a second episode of salpingitis, what is the likelihood that the woman is infertile? Okay, the student looks at this and says less than 20%, 20 to 30%, greater than 50%. Okay, so you say, C it already includes D and E. What is greater than 50%? 90% greater than 50%, 75% greater than 50%. And the first 2 are ranges, first 3 are ranges, D and E are absolute numbers. So coming to the issues of irrelevant difficulty. Options are long, complicated, or double. Numerical data are not stated consistently. Terms in the option are vague, rarely, usually. Language in the options is not terrible. Options that are non-logical order. And stems that are tricky or unnecessarily complicated. Okay. So another example of a flawed item. Okay. We don't have to read the question. There's a clinical history. And the question is, which of the following is the most appropriate next step in patient care? One of the choices is none of the above. Okay. And I've seen this, and national boards actually have done psychometric analysis of these types of questions, which are none of the above. They have the question answered by 10,000 students, and then they find out, who got the right, or in what quartile they were in. And there are well-defined psychometric methods to test these things. And if really the goal is that none of these treatment is appropriate, okay, you make the answer observational only. Which of the following is the most appropriate next step in pharmacotherapy? Observation only. Okay. Now, because observation only is a decision you will make when you're seeing the patient. You will say, let's observe this patient. Okay? You won't make the judgment, none of the above. Do you see? So this is sort of in keeping with how one actually practices medicine. Criteria for evaluating item quality. Does that item test important content? Okay. I've seen, and you have seen, questions in various exams where they will ask you questions of an obscure rare disease and obscure gene and ask you a functional gene. Why? Because they think this is a way of making a difficult question. In fact, it's a way of making irrelevant questions. Irrelevant question, if irrelevant question is difficult, it doesn't really meet the goals of our assessment. Is the term clear and ambiguous? Is the item flawed? Will it confuse a knowledgeable student? Does it have irrelevant difficulties? Does it provide special benefit to test wise student? That was the convergence question that I showed. Now there are multiple competing roles of assessment in mental health medical education. And these are the goals. The important ones are communicating to students what material is important and motivating them to learn it. This requires well-written up competency and objectives. Encouraging horizontal and vertical integration through cross-clinical assessment. The question which requires knowledge of physiology, anatomy, and pathology. Monitoring student learning and encouraging retention. Okay. And the last, and not the least, evaluating and improving the educational program. We give exams, we give tests, we give multiple questions, and we find that 3 or 4 questions which we thought were relevant, everybody should know that, only 10% got correct. Which basically a message to us, we didn't discuss that or make the students understand that sufficiently for them to answer these questions. Okay? So it's also a guide to the faculty. And finally, a term which you have heard many, many times, assessment for learning, not just assessment of learning. Assessment for learning. And there are examples of multiple choice questions for clinical subjects, and we can go through these quite quickly. Again, key goals for assessment in clinical education. There are various ones, but I think the highlighted ones are promote the integration of knowledge across clinical experiences, preparing students to provide care and post-graduate education. When you're teaching undergraduates, you're preparing them to, go to post-graduate education. Promote retention of basic science and clinical knowledge as students progress through training. Encourage students to identify and remediate their weaknesses. Communicate to students and faculty what materials are important and motivate students to learn broadly, not just the patient they happen to encounter. Again, well-written competency and objectives. Finally, the same common goal, assessment for learning and not just assessment of learning. Okay, so here is the clinical question, which has been converted from recall to test of application. The recall version says, what is arterial blood test what is the arterial blood test analysis most likely to show in a patient with cardiogenic shock? Okay, this is a recall question. Okay, cardiogenic shock has metabolic acidosis or metabolic alkalosis or respiratory acidosis or whatever, any of those five. Some one of those five. One can convert this into an application version. And using the same option list, you can give a history of somebody who's in cardiogenic shock. That requires synthesis now. It requires synthesis of clinical medicine, some physiology, understanding of acid-base balances, and then the question says arterial blood gas analysis is most likely to show which of the following. That was the same very thing in the recall version, except now it's placed after giving a clinical scenario. So it's the application version. So next several questions are examples of what sort of things you can ask and give a question. You can ask which of the following is the most appropriate next step in diagnosis. bronchoscopy, angiography, homogeneous. All of them are interventional procedures. What is the most appropriate initial management? Give a clinical history, and it could be supportive treatment at home. Do this, do that. All homogeneous choices. Disease mechanism. You give the history. I think it's called patient had aortic stenosis. Which of the following is the most likely cause of these findings? Calcification of bicuspid aortic valve, tricuspid aortic valve, atrial septal defect, VSC defect, and infected endocarditis. You can ask questions on history taking. Okay. The patient presents with this history. Which of the following questions is the most appropriate to ask first? Okay. So here, what you're testing is history taking skills and also judgment of what is the sequence in which one should ask questions for a patient who presents with chest pain. Several examples for MCQs for basic science courses. I think we've seen this slide before. And again, may I emphasize, avoid esoteric or just interesting topics that are not essential. You may have in your lecture, given students, want to give students an understanding of the cutting edge of what is going on. You may want to tell them that this new gene has been discovered, and this controls the metabolic activities of the cancer cells. And it may become an important target for treatment later on. Okay. You are excited about it because it was published only about 6 months ago. You read it and you said, wow, this is beautiful, this is wonderful. Okay. Share with the students, but please don't ask them questions. Because you're just sort of going away from the big picture to a level of narrowness that is not required for undergraduate medical school. The students always complain that the faculty tell them, oh, you should have these things, and when they ask a question, is obscure. And that leads to mistrust between the faculty and students. So, in nutrition, recall of an isolated fact. Which of the following vitamins or minerals is involved in clotting factor synthesis? In this question, there are more than 5 choices. We don't use anymore these multiple choices. We use only 5 choices. But it's all right. There's nothing wrong with it. You can use whatever you want. The same thing converted into an application of knowledge. 70-year-old widower has ecchymosis, peripheral tachycardia, swelling of gingiva. His diet consists primarily of Coca-Cola with hot dogs. Which of the following vitamins and minerals most likely deficient? You're still asking the same question, action of vitamins. But you're asking it in a context where they have to apply knowledge. Biochemistry, isolated fact item, recall. Acute intermittent porphyria is the result of its effect in biosynthetic pathway of collagen collagen. Convert this into an application. Give a history. And from the history, the student should be able to sort of figure out, what the diagnosis is, and then say, these findings suggest a defect in the biosynthetic pathway, which of the following? The answer was E. In this case, A is the porphyria. This question you may think is too difficult for undergraduates. That's perfectly all right. I'm not trying to give you questions for just undergraduates. I'm just trying to give you questions that are good questions and are aligned with the competencies and objectives. This is an anatomy question. Okay. There's a clinical history. There's a mass at the angle of the mandible. Which of the following is the most likely diagnosis? The patient has difficulty in walking and straightening the trunk. Which muscle is most likely injured? Physiology. Patient has histories of diabetic ketoacidosis, and the questions are the cluster of pH, PO2, PCO2. This is a difficult question, but it's an appropriate question. Even undergraduates should know, how good, what sort of a management and diagnostic modalities are there for the very common conditions diabetic ketoacidosis. Microbiology question. People go for a picnic, eat fried chicken, and then somebody becomes ill, and it's food poisoning. Which of the following bacteria will be found? Pharmacology question. Clinical scenario. Which of the following drugs is most appropriate to give in the next patient care? Using images. There's a section of the brain. 48-year-old woman has loss of pain and temperature sensation in the left upper lower limb. The causal defect is most likely present in which of the label structures? So your choices are A, B, C, D, E, various structures. Student has to know the anatomy of that area and has to be able to function related to the clinical features. Students don't mind learning these things if they know why they're learning them. Again, a pictorial material. Male unit shown in the photograph will be evaluated for surgical recommendation. The most likely cause of these findings is the deficit of neuropressurized vision concerns in which of the following areas. It's somewhat of a difficult question, but again, if the student knows, if you're testing embryology, this is a reasonable question to ask. I picked this question because once somebody asked me, oh, I'm a biostatistician, and I know how do I ask questions? Well, you ask questions by giving them an epidemiology extract. You give them the two drugs X and Y are being evaluated, subjects are selected, half are scientific drug X, half drug Y. Okay. 1 month later, and the question is which of the following best describe this by design? It's a crossover study. And golden rules for best answer items. I think we discussed most of these. Okay. And in the last few slides, I want to just show you. I did a workshop on this exact same topic, alignment of objectives, competencies to assessment methods. And in the workshop, we asked the participants, your colleagues who came there, to create some aligned examples. And so these were created. Tuberculosis, the competency, the objective, the question. All of them.